Okay, good evening, everybody. Let's start with the session of question answer session. I'll start with Dr. Nitin from Belgaum. Dr. Nitin, are you there? Anybody who can hear my voice? Please.
Yes, sir.
Yeah, okay,
Yes,
fine.
sir.
Yes, sir.
Yes, great. So Nitin is not there. I'll move on to Dr. Pratibha Dhingra from Nagpur.
Yes, sir.
Pratibha, the question goes to you. The
Yes,
first
sir.
question is, what are the structures seen in this plaque's view from top to bottom? What is this structure?
So right ventricle,
This
interventricular septum,
is interventricular septum. What is this?
aortic annulus, aortic root,
Which aortic root?
so
Anterior aortic root.
anterior aortic root. Okay.
What is this?
This is posterior aortic root.
What is this?
This is aortic annulus.
This is aorta.
Aorta, okay.
This is
Interventricular septum.
anterior interventricular septum. Anterior interventricular septum.
Okay. This is anterior mitral leaflet,
Here.
posterior mitral leaflet.
This.
This is left ventricular posterior wall, lateral wall, and this is left no. This is left atrium.
So you have got two left atriums, right?
No, no, sir. This is what?
This is descending aorta.
Okay.
So remember
Okay,
this
sir.
descending aorta, okay?
This is descending aorta, no?
Right. I'll request everybody, please mute their mics. So this is descending aorta, okay?
Oh, okay, sir.
You were
Thank you.
close, but you are not 100% right. Anyway, still good answers.
Thank you, sir.
Thank you. Dr. Nitin?
Yes, sir. Can you hear me, sir?
Yeah, I can hear you joined just now.
Yes, sir.
Tell me, Nitin, what is the structure seen in this short experiment?
Sir, these are the two papillary muscles, and this is the RV above that.
What is this?
Sir, that is the LV it is at the mid cavity level, sir.
Okay, what is this?
Sir, that is the interventricular septum.
What is this?
Sir, I cannot see that very clearly, but that looks like septum, sir.
Septum is here. What is this structure? Okay, opposite septum, what is this segment?
Opposite the sir, in this picture you mean, sir?
Yes. Opposite septum, what is this segment?
Sir, that is the posterior segment, sir.
Septum is opposite posterior segment. Anterior septum is opposite posterior septum. So this is anterior septum, this is posterior segments.
Okay, sir. Okay.
So septum opposite is, remember what's there in four chamber view? Septum and lateral wall. So
lateral
this is
wall,
lateral
yes, sir,
wall papillary muscle.
Yes, sir. Yes, sir. That I knew, sir. Yes, sir.
So this is anterior segment, this is posterior wall.
Yes, posterior wall,
This is anterior wall,
sir.
this is
And inferior, sir.
wall. So inferior wall. So this is inferior wall, this is lateral wall.
Lateral wall. Yes, sir.
Septum and lateral wall, anterior septum and posterior wall,
Posterior septum.
anterior wall and inferior wall.
Yes, sir.
I hope you remember now.
Yes, sir. Yes, sir.
All right, we'll move to Dr. Jha, Virwar Kumar Jha, Patna. Dr. Jha, are you there? All right. Dr. Ankit Seni. Ankit Seni, are you there? Dr. Shashank Sunil Tuse. Dr. Shivaji Vithoba Mali.
Yes, sir.
Shivaji,
I'm there.
Okay,
Yes,
Shivaji,
sir.
your question comes over here. What are the structures seen? Wait a minute. In this view, apical three-chamber view. What is this structure? What is this structure?
This is LV.
I know everything is LV. Yeah, Rakesh Gupta is a man. So this is LV. So what is this part of LV?
Interventricular.
No, it's not interventricular septum. It's very classical. It's three-chamber view. Look, this option says three-chamber view. So what is this? All right. What is this?
This is
All right. What is this? What is this?
mitral wall.
What mitral valve?
These are the cardiotendony.
What is this? What is this? Cardiotendon is over here.
Yes, a cardiotendony.
What is this?
These are the leaflet of mitral wall.
Which leaflet? Shivaji, you read. You're enjoying. I give you 0 out of 5, 0 out of 5. You have to read. This is not the correct answer. None of your answer is right. Let the next person take up this question. Dr. Harshvardhan Kuri from Rajasthan. Dr. Harshvardhan, are you there? Listen to Dr. Harshvardhan on the next participant. Dr. Pallavi Horo from Lucknow. Anchal Dikshit, Lucknow.
Yes, sir.
Anchal, tell me the structures.
Sir, this is anterior septum and that is the
Perfect.
posterior
This-
wall.
Correct.
And this is the close to the aorta is the anterior mitral leaflet and the posterior mitral leaflet. is
Correct.
below.
And what is this?
Aorta.
What is
Aortic
this?
valve and right ventricle.
Right ventricle. Are you clear, Dr. Mali? Now?
Yes, sir.
So you'll have to really look at this, what she's saying. She said in 3 minutes, everything in one go. It's a very simple thing. And we had discussed this point a few minutes back only. Just a few minutes back when I was talking of a short axis view. Good, Anchal. God bless you. Let's move to Dr. Saurabh Gupta from Udaipur. Saurabh, are you there?
Yes, sir, I'm here.
Yeah, get ready, Saurabh.
Okay, sir.
This is structure seen in apical two-chamber view. What is this?
Sir, anterior wall of left ventricle.
What is this?
Inferior wall.
What is this?
Sir, papillary muscle attached to the.
Which papillary muscle?
Posterior.
Papillary muscle, and you are saying inferior wall, papillary muscle is posterior wall. How can be inferior, posterior, papillary muscle?
Papillary muscles is attached to the inferior wall, sir.
Correct. So papillary muscle is only attached either to inferior wall or lateral wall. So it is
Lateral
inferior wall
wall.
papillary muscle. What are this?
Sir, mitral wall leaflets, anterior mitral leaflets.
Basically, these are cords.
Cords, sir.
And can you divide this anterior wall into 3 segments?
Sir, apical, mid, and basal segment.
Right. Inferior wall.
Inferior wall also, sir, into 3 segments, sir. Apical. mid, and
Why we call them as a mid segment?
Sir, we call it because the papillary muscles are attached there.
Perfect. Great. Good, Saurabh. Good attempt.
Thank you, sir.
Thank you. Dr. Arnab Kumar Mandal, next. Are you ready, Dr. Arnab? He is not there. Dr. Avinash Solanke.
Yes, sir.
Okay, get ready, Avinash. The next question comes
Yes.
for you.
Yes, sir. Yes, sir.
Oh, I'll have to move on this slide. So what are these structures in four chamber view?
Sir, this is a apical segment. This is a, sir, sir, basal apical septum, sir. This is a mid septum, and this is a basal septum, sir. This is a, sir, apical anterolateral, mid anterolateral, and basal anterolateral, sir. This is papillary muscle, sir.
You're confusing between 16 and 17 segment models. So either remember 16 or remember 17.
Okay, sir. Okay, sir.
This is apical lateral. This is basal and mid anterolateral segments.
Okay, sir.
What is this?
This is, sir, RV.
What is this?
Sir, tricuspid wall.
This one?
Sir, right atrium.
What is this?
Which one, sir?
Here.
Sir, fourth chamber. Sir,
All right. What is this? Okay. You are able to give a very good answer till about this segments. We would like to try, make some guess. What is this structure could be?
Pulmonary vein.
Oh, actually, nobody asked you pulmonic veins. Pulmonic veins is not there.
Inferior vena cava.
Descending.
Descending thoracic
aorta.
Descending aorta, sir.
Coronary sinus.
thoracic aorta.
LA appendage.
One by one, let me hold. All of your answer is wrong.
Coronary sinus.
Coronary sinus vein.
Coronary sinus on this part. Left side coronary sinus drains to right ventricle, man.
Descending thoracic aorta.
Descending aorta is here.
Here. Okay.
LA appendage, sir.
It could be either LA appendage or it could be a left upper pulmonic vein. Left lower pulmonic. It all depends on a flow because both the locations talk of the same things. So don't jump in between. I'll ask for my next person because that will be the bright way of asking you, right? Okay, great. Solanki, you did a really good job, but read about these structures.
okay.
We have right pulmonic vein, one over here, one over here. This could be a left pulmonic vein or LA appendage, and this is definitely a descending aorta.
Okay.
Now, next question goes to Dr. Sangeeta Chaudhary. Sangeeta, are you there?
Yes, sir.
Good. Sangeeta, suppose I say this is aorta. How will you say that this is aorta?
Which one, sir? This lower one.
This structure is aorta. How can you confirm that this is aorta?
With a color flow mapping.
Color flow done. Color flow will be seen in this. I say it's a pulmonic vein.
So
Then-
we can do the measurements. We can see the gradients. We can take the after taking the color flow Doppler. We can trace the envelope, and then we can looking at the envelope, sir. We can see if it is.
What you see in the envelope?
So in the pulmonary vein, the envelope will be below the baseline.
You are close, Sangeeta. Think what is the difference between vein and artery?
So in pulmonic vein, we'll be able to see the reversal of flow.
Pulmonic vein reversal of flow. Do you see reversal of flow in pulmonic veins?
Sir, there will be three waves. One is S wave, systolic, diastolic,
And
and
atrial reversal kick. This atrial reversal
sir.
kick is majority of time can be seen, but that's not be very valid because we are almost oblique in evaluating left upper pulmonic or lower pulmonic veins. Suppose this is aorta.
Okay, sir.
So I am not, please do not go away. I'll ask this question from Ashok Yadav from Delhi. Ashok, can you take up this question? Are you there or not there?
So I am here.
So can you take up this question? Can you prove that this is aorta? No, you cannot prove it. Dr. Birata Debarama from Assam, Agartala.
Yes, sir. This aortic valve be in continuous with the left anterior leaflets or
Descending
aortic
aorta, how can you
valve
look at
there
aortic
with
valve? No. Just hold on. Three of you cannot answer. Anybody who knows about it can raise the hand. None. Dr.
sir, it is
Saurabh.
enclosed in the sheath.
Wait a minute. Saurabh, you want to try?
Sir, do we look for the human variation with inspiration?
Dr. Swapnil,
Sir, it is pulmonary veins. Sir, it is pulmonary veins.
Dr. Anuj,
Sir, it is pulmonary vein.
Dr. Narendra Kumar. I'm saying this is descending aorta. How can you prove this is descending aorta?
So aorta will not collapse, but pulmonary vein will collapse. And in color mapping, sir, the direction of the color of the flow will be blue color in descending aorta.
No, it's wrong.
We put this at pulse Doppler.
Narendra, go ahead.
We put this at pulse Doppler at the site of that region, and we change it like any type of
Narendra is correct. If you put a pulse Doppler into it, it will show arterial blood flow or pulsatile blood flow, whereas if it's a vein, it will show a respiratory variations. And I request everybody, please silent your mics. Please silent your mics. A lot of noise is coming in between. Dr. Sunita Kaul, please silent your mic. So Dr. Narendra is correct. Dr. Narendra, you are correct. You put a sample volume into this descending aorta. If this is a descending aorta, it will show a pulsatile flow. And if it's a pulmonic vein, it will show a respiratory flow. And we cannot depend on collapsibility. How can you collapse these structures? Good. So we go back to next again to Dr. Solanki. Dr. Narendra gave a perfect answer. Let me just mark something good for him. So everybody is happy with this answer?
Sir, what about the size shape? Like artery will be circular and vein will be a bit
It's not seen over
so
here.
circular, and the wall will be thin.
It's not seen over here. We only differentiate by putting a Doppler spectrum pattern across these two structures, and then we decide what is this. If it's a pulmonic vein, it will show a color flow, which will have a respiratory variations. And on the other hand, if it's a left atrial appendage, there will be no color flow in LS. All right, let's go back to Dr. Sangeeta Chaudhary. Ready, Sangeeta?
Yes, sir. Yes, sir.
Index marker for probe in plaques window.
In plaques, index marker should be looking towards the right shoulder, that is 11 o'clock position.
And where do you keep your probe?
So we keep in the left third intercostal space.
Left third intercostal space. Perfect. Great, Sangeeta. Perfect answer.
Thank you, sir.
And now, Dr. Ashok Yadav, back again. Index marker for probe for plaques, P-sacs view at papillary muscle. Ashok.
Side 1 o'clock position.
Where?
In the same third intercostal space.
Third intercostal space. Okay, 1 o'clock or 2 o'clock. It all depends. Nobody knows about them. Great. Dr. Birata Devarama. How do you make
Sir.
short axis view from at aorta, mitral valve, and papillary muscles?
Um,
First of all, where do you keep the probe?
Sir, from the P6 view, sir, I'll be doing. Sir, it is at the same level of the plex, at left heart intercostal space, and from there, I'll angulate the or slide the probe, and at the level of aorta, I'll see the aortic valve like Marcy design. In case of at the level of mitral valve, I'll see the two leaders of the mitral valve.
No, my question
And
is
the
little different. No, hold on.
I have to
My question is
angulate,
very different.
adjust
My
the
question,
proof,
Birata, my
and I'll see
question is
the
different.
papillary from the anterior and lateral posterior.
No, my question is different, Birata. Next time you should have a better internet connection. Your voice is cracking in between and it's slow.
Okay, sir.
First of all, my question is, how do you make short axis view at aorta, mitral valve, and papillary muscles? My question is entirely different. How do you make short axis view from mitral valve, aorta, and papillary muscles? Do you know how to make it?
Sir, I have to slide or angulate the proof, sir.
Okay, I'll ask you a very simple question. How do you make from Plaque's window to short axis window? Plaque's view to short axis view at aorta?
Sir, from the plex view, I'll rotate the probe at the right to rotate the probe, and I'll get the P6 view.
P6 view. From P6 view, how will you make aorta, mitral valve, and
Yes, sir.
papillary muscles?
Sir, I have to angulate the probe anteriorly, sir. Then I'll get the at the
I told
outer
you
level.
very categorically, let the footpin looks towards right shoulder, you will get aorta. Come back perpendicular at mitral valve, come back perpendicular left
Yes.
intercostal space, you will get mitral valve. And just let the
Yes,
footpin
sir.
looks towards left hip, you will get papillary muscles and apex. Remember, you are not able to see very categorically,
sir.
Birata. Okay. Okay, Dr. Venkatesh,
Okay, sir.
get ready.
Okay, sir.
Venkatesh, are you there?
Yes, sir. Yes, sir. Yes, sir.
Next question goes to you, Venkatesh.
Yes, sir.
Index marker for apical four-chamber view. You don't have to take so much of
Sir.
time.
Yes, sir. At apical view, sir.
Yes, apical four-chamber view. All right. How do you make from four-chamber, two-chamber to three-chamber?
From sir, index marker at apical view, we can see that the four-chamber view, sir.
Index marker in apical four-chamber view. Where do you keep index marker in which particular window? Where? All right, Dr. Piyush from Gondia, are you there? Dr. Piyush. Dr. Pankaj Mishra from Bhubaneswar. Pankaj, are you there? No. Ajit Balasaheb Dangle.
Yes, sir.
Tell me, how do you make this view?
So index marker for apical four-chamber view, we keep the probe at the apex, and the index marker should be facing at 3 o'clock position.
Okay.
And to make it 2-chamber and 3-chamber view, we rotate the probe counterclockwise for 2-chamber and 3-chamber view.
Perfect. Did you hear Dr. Venkatesh?
Sir, I'm here,
Yes,
sir.
yes,
Dr.
sir.
Pankaj here, sir.
Yes, I got.
Okay. So he gave you the right answer. Left apex, left fifth intercostal space, 3 o'clock position, parallel to heart. Rotate counterclockwise, make it 3-chamber, 3 to 4, then 5, 4 to 3, and 2 chambers. Good, Dr. Danley.
Sir, Dr. Pankaj here. I'm here, sir. Hello.
Okay, Pankaj, I'll ask you next.
Sir.
Get ready. I marked you absent otherwise.
Sir, my microphone have some issue. For that reason, I cannot connect.
All right. Anyway, your microphone is okay now?
Right, sir.
Okay. Next question is good. You. Index marker for RVRA inflow view.
This short axis view at the level
Index
of outer.
marker at RVRA inflow view.
At 1 or 2 o'clock position, sir.
Index marker for RVRA inflow view. All right.
Sir.
How do you make this view?
This is the short axis view around out.
How do you make this view? This is not purely a short axis view at aorta. This is modified short axis view at aorta. It is known as something else. I told you about this view. And this view is related with this kind of a RVR inflow view. Okay, Pankaj, we'll give a try to somebody else, right? And then you listen to his question, answer very carefully.
Hello.
Doctor, yeah.
Hello, sir.
Yes, Pankaj.
I'm muted actually. It can. It is the short axis view showing RA and RV.
What is this structure? What is this structure?
This is the a pulmonary artery. RV, then pulmonary artery.
This is RV. This is pulmonary artery.
Pulmonary artery, right, sir.
So how do you make this view? This is focused pulmonary artery.
Focused RRV view, sir.
This is not RVRA view. Where is RVRA?
No, sir. It is a focused pulmonary artery view, sir.
How do you make? Where is the index marker for RVRA inflow view?
So same 1 o'clock position.
No. Read now. Let's listen from Dr. Kiran Vasantrao Birari from Nasik. Kiran, are you there? Dr. Kiran Vasantrao. Dr. Rohtaj Singh Kalsi from Gurdaspur.
Yes, sir.
Tell me, Rohtaj, what is the index marker for RVR inflow view?
Sir, it is at 11 o'clock position, sir.
How do you make RVR inflow in 11 o'clock position?
Sir, so we have to tilt the transducer, sir, medially or right side so that the footprint starts like it looks towards the mediastinum.
Correct. So from where you will take the transducer?
Sir, in the third intercostal space, index marker at 11 o'clock position.
So first we'll make Plaque's window, and then you will tell the footprint start looking toward mediastinum. Then you get RVR inflow view. And what is this view is?
Sir,
how do you make this view?
Sir, hello. Sir, I'm not able to hear you.
How do you make this view?
Sir, is this a parasternal short axis view at aortic level, sir?
No.
Yes.
Parasternal short axis view at aorta will show RA, RV, then RV, OT, and then pulmonic artery.
Yes.
Dr. Sandeep from Delhi. Sandeep,
Yes, sir. Yes, sir. Good morning.
how do you make this view?
Sir, from the plex view, clockwise rotation of the probe about 90 degree, and the probe pointing toward the patient left shoulder.
Good. This is basically, as we see RVR inflow view, this is pulmonic artery outflow view. As we tilt our transducer from paraplax window towards mediastinum, you tilt your transducer towards left shoulder, you'll get this pulmonic view. Otherwise, you can rotate your transducer 90 degree and let the footprint looks towards pulmonic artery. Left footprint looks towards left shoulder.
Yes, sir.
This is right pulmonic artery, this is left pulmonic artery. So, Dr. Rohtas, what is this? Dr. Sandeep, what is this?
Sir, this one is not no, sir.
Dr. Prakhar from Firozabad.
Yes, sir.
Yes, sir. What is the structure, Prakhar? What is the structure?
Aorta.
What is the structure?
I cannot see the
Here. Descending aorta. Next time, Prakhar, you have to have a good internet connection. I hope you are not on mobile phone.
No, sir. No, sir.
So this is descending aorta, correct?
Yes.
How will you prove that this is descending aorta?
So with the help of pulse wave Doppler.
Perfect. Great. Good job done, Prakhar. Just hold on. Don't go away. Name 16 segments of the heart, Prakhar.
So starting from the apex level, anterior, inferior, lateral and septal. Then at the papillary muscle level, anterior, inferior, septal, then lateral, anterior lateral, then inferior lateral. Then coming on to the mitral valve level, you get the anterior, inferior, anterior septal.
Prakhar, the best way of talking about this segment is not by short axis view. Best way is talking about apical 4-chamber, 2-chamber, and 3-chamber view.
Yes, sir.
Yes. So tell me 6 segments of the apical 4-chamber view.
Basal septum, mid septum, apical septum, then apical anterior septum, mid and basal, apical anterior.
Again, you're confusing. Anyway, it's okay. You're confusing amongst many, like 16 versus 17 segment models. It's fine. It's acceptable. Let's move on to Dr. Chitranjan Thatai from Cuttack. Dr. Chitranjan, are you there? Chitranjan. Dr. Sarada Prasanna Sahu.
Yes, sir.
Tell me 6 segments of the 2-chamber view.
Apical mid segment, papillary.
First of all, what are the walls in 2-chamber view?
Valves.
Walls. Which walls?
Mitral valve and aortic valve.
No, I'm not talking of valves. I'm talking of walls. Walls.
Sorry, sir.
No idea?
No, sir.
Okay. Dr. Subhash Chandra from Agra.
Yes.
Dr. Subhash, tell me the 6 segments of the 2-chamber view.
chamber views. One is apical inferior, mid inferior, basal inferior. Then apical anterior, mid anterior, and basal anterior.
Okay, let's move on to three chamber view. What are the segments in three chamber view?
Apical lateral, inferiolateral, basal inferiolateral, and apical anterior, mid anterior, basal anterior.
Okay, good, Dr. Subhash. Great job done. Dr. Sofinar Islam from Assam. Are you there, Sofinar? Dr. Islam from Assam. Dr. Pratap Jagtap, Nasik. Are you there,
Yes,
Dr.
sir.
Pratap?
Yes, sir. It's Pranjal, sir.
Pranjal. I'm sorry. Pranjal Prakash Jagtap.
Yes, sir.
Pranjal, are you ready?
Yes, sir.
Please silent everybody's mic. Somebody has got the mic which is open. Pranjal, tell me this. This is a four-chamber view, right?
Yes, sir.
This is what segment?
So that is apical interventricular septum,
What is this?
mid interventricular septum,
What is this?
basal interventricular septum,
What is this?
apical lateral. Yes, it is apical lateral wall, then mid anterolateral wall, and basal anterolateral wall. Sorry.
Okay. So what is the supply of this apical inferior wall, apical septum?
So for apical, it is one second. LAD. For apical, it is LAD. Then
And
for
this
sorry, sir.
here?
So for the whole lateral wall, it is either LAD or LCX. That is
Okay.
circumflex. Then for the mid septum, it is RCX. I think. I'm not sure.
RCA.
RCA. And for the basal, it is RCA or RCX.
There is nothing like RCX, either RCA or LCX,
LCX, sorry. Sorry, sir.
right?
Yes, sir.
How many arteries are there in the heart to supply the, how many coronary arteries are there in the heart to supply the heart?
So two coronary arteries, right coronary and left coronary.
Left coronary divides into?
The left coronary artery divides into left anterior descending artery. And then if it supplies the interventricular septum, then it gives left circumflex artery. So actually there are two, like D1 and D2. I'm a bit confused now.
I'll just clear it up. And like LAD, left coronary artery supplies, divides into two, circumflex and LAD.
Yes, sir.
LAD give rise branches like D1, D2, D3.
Yes,
circumflex give rise OM 1, 2, 3.
Yes, sir.
And they divide and then supplies the heart.
Okay.
Okay.
Yes, sir.
Great. Good job done, Pranjal. God bless you.
Thank you, sir.
Dr. Deepak Suman from Baran, Rajasthan. Dr. Deepak, are you there? Dr. Deepak Suman. Rupali Sanjay Sawant, Goregaon.
Yes, sir.
Rupali, the question is, this is two-chamber view. What is this segments of the heart?
So this is anterior wall.
This
is inferior wall.
Anterior wall. Can you tell me the blood supply of this anterior wall over here?
LAD, sir.
This
circumflex. No. The whole anterior wall is LAD and inferior wall, basal and mid is RCA, and apical it is LAD only.
Good. So, Suman, Dr. Rupali, can you tell me how many segments are supplied by LED?
LED.
Suppose I've got a 16 segment model in the heart. How many places the LED supplies?
Sir, except basal
I'm asking you
inferior.
number of segments.
Number of segments.
You have done your question. This is the bonus.
I think 10, sir. Out of 10.
Okay. You are not correct. You are close to correct. I'll ask for my next person. His name is, her name is Dr. Not Dr. Archana. Archana Kishore Sinalkar from Mumbai. Archana, are you there?
Yes, sir.
So tell me, Archana, how many segments LED supplies? She says 10. Are you agreeing with her?
Six, sir.
Oh, Archana, you have disappointed me very badly.
Or just a minute, sir.
In a minute's time, it will change?
10, sir, 10.
Oh, she said 10.
Sir, I agree, sir. I agree.
You agree with it?
Yes, sir.
Dr. Madhurima Datta from Silchar. Madhurima, are you there? Dr. Madhurima Datta.
Yes, sir.
Oh, you came up. Okay. Tell me, Madhurima, how many segments are supplied by LED?
So 6.
Oh, Madhurima, that's not fair. Somebody will die because of few segments not supplied by LED.
So the apical segments, sir. So then
All right. We'll hold up this question now. Okay, tell me, Madhurima, I'll take up a next question from you before I come back to these people again. This is what? What is the structure, Madhurima?
So the septum.
Oh, Madhurima, you're also not reading at all. What is this structure?
So this is the so LV, so so free. So this is the
Madhurima ji, spend some time. You had a good Diwali holiday, and now you are still in a Diwali holiday mood. Correct? Even if you listen to our basic lecture at least one time after your lectures, believe my word, things would be much easier. Okay. Let's go back to go back to Rupali. Rupali, what is this segment, sir?
Sir, this is inferolateral wall, basal inferolateral, mid inferolateral, and apical lateral. And opposite to this is anteroseptum. Basal anteroseptum, mid anteroseptum, and apical septum.
Okay. What is the supply of this segment?
So circumflex, basal and mid circumflex, and anteroseptum, whole anteroseptum is LED.
All right. What is the supply of basal anterior septum?
Basal anterior septum, so circumflex and LED only. So.
LED which branch? Remember, it's a D1 branch of LED.
Okay, sir.
Right. Good job done. Let's move on to Archana Kishore Sinalkar.
Yes, sir.
Archana, how do you calculate ejection fraction from apical 4-chamber view?
So by taking volume,
This is the second attempt.
LV, sir, LV volume.
No. Dr. Madhurima, you want to try?
Sir, we take, sir, LV, sir, we will draw a map, sir. around the border. So and then so we'll take the one diagonal line from the apical to the basal segment, sir, and then we'll divide it, and we'll take the fraction.
Dr. Mahesh Patsalke.
Yes, I am there, sir.
Yeah, please tell me how do you calculate ejection fraction of apical 4-chamber view?
So, this 4-chamber view we can calculate with modified Simpson's formula,
right?
Where we can trace from annulus to annulus the endocardium at end diastole.
I'll start showing it. Annulus
from
to annulus.
this annulus to from endocardium to whole left ventricle, except Purkinje fiber at another other annulus. Then you just click it in the inter, then automatically, and then you take a long axis, and afterwards automatically whole left ventricle will be divided into 16 different packages.
Multiple diskettes.
Diskettes
So
actually.
individually disket has got a volume, and that volume when added together will give you end diastolic volume.
End diastole. So this has to be done at end diastole and then end systole, and then automatically machine will calculate the ejection fraction.
So both Archana Sinalkar and Dr. Madhurima Datta, listen, what we do is, first we go to the end diastole. In end diastole, LV would be maximum in size. We start with one annulus, trace along the border, go to apex, come back to lateral annulus, and then click, it will join automatically with a line. From the center of this line, draw a straight line. So this is what you draw. This you draw an area. Area into length will give you volumes. And these segments are divided into multiple diskettes, and machine will give you end diastolic volume. The same thing is repeated at end systole. So it will give you end systolic volume. End diastolic minus end systolic divided by end diastolic volume will give you ejection fractions. Is that clear?
Yes, sir.
No,
Yes.
I'm not asking you. I'm asking Madhurima Datta and Archana Sinalkar.
Yes, sir.
Both of you have to read a lot. Despite 2 attempts, you are not happy. Okay, let's go to the next question. This is for Dr. Bhagat Vibhusha Vishwanath. Are you there, Dr. Vishwanath?
Yes, sir.
Dr. Vibhusha, your name is Vibhusha, right?
Yes, sir. Yes, sir.
Vibhusha, tell me the coronary artery supply of right coronary artery.
So right coronary supply. Sorry. There's a posterior right ventricle. There's a posterior wall, right ventricle. And,
obviously, right coronary artery will supply to right ventricle, left coronary artery will supply to left ventricle. Very simple.
yes, sir.
That's not right.
Yes, sir.
That's not right, right?
Yes, sir.
Okay, let's take this question, give it to Dr. Dheeraj Kumar Singh. Dheeraj? Dheeraj from Delhi. Dr. Sanjeev Mathur from Jaipur. Sanjeev, are you there?
Yes, sir.
Tell me the right coronary artery supply territory.
So it supplies the right ventricle and a part of the basal septum.
No, that's all.
So and the right ventricle and the posterior wall of the right ventricle. Yes.
Dr. Niranjan Agrawal from Bhilai. Niranjan, are you there? Bhimaraya D from Bangalore. Dr. Rajesh Gudade, Gangapur. Rajesh, are you there? Yeah, Rajesh, I could see your name. Tell me, Rajesh, what is the supply for right coronary artery?
In a 2-chamber view, as just discussed, it will supply to inferior wall, and a long axis view, when we see it will supply to the LV posterior wall. Then whenever we see the fourth chamber, sir, am I saying correct or sir?
You're wrong.
Hello.
So anybody who want to raise their hands, all of
I
four people have
got
got
the
right.
question.
Shashank.
Dr. Prasenjit, sir.
Yes, sir. Sir, the right ventricle is supplied by RCA. Also, in the basal septum and in four chamber and in two chamber, basal and mid inferior. Am I right, sir?
Shashank, to a large extent, you are right. You are missing one segment. Right ventricle, of course, is supplied by right coronary artery, but mid and basal septum, mid and basal inferior wall are supplied by RCA.
Okay, thank you. Sir, I'm present. Maybe I was marked absent.
Okay, Rajesh. Shashank is fine. Please silent your mic. Somebody is listening to music and TV simultaneously. Believe my word, it is really offending all the times when I'm requesting you. And next time I hear this voice again, I'm going to pick up that person and shunt you out. Till now, 9 times I have requested this thing. Please silent your mics. Either you listen to TV, listen to your wife, listen to your husband, or you listen to this lecture. The next question goes to Mr. Rahul Kumar from Delhi. Rahul, are you there? Rahul Kumar.
Yes, sir.
Coronary artery supply of LAD.
Sir, in two chamber view, it supplies the basal inferior.
Let's go to four chamber view first.
Sir, in basal, sir, four chamber में basal in infroseptum view.
Interoceptum. There's nothing like infroseptum in basal view supplied by LAD.
Sir, four chamber में sir mid and basal septum.
Mid and basal septum are supplied by LAD. Rahul, read. If you do not know the answer, say no. I do not know about it.
Sir, LAD. Sir, give me a moment.
Okay, I'll give you a moment.
Sir, can I tell you in two chambers, sir? This is the.
I want four chamber first. Just think over. I'll come to two chamber. Dr. Vibhusha, will you try this question? Dr. Vibhusha.
Yes, sir.
Four chamber.
So four chamber. So are we?
LAD territory.
So apical region.
I don't know what is the apical region in four chamber.
So sorry. Five segments are there.
Apical segment, 5 segments are there. I'm asking four chamber. You're talking of apical 5
So
segments.
four chamber, apical lateral, apical septum, mid introseptal.
Let's go to four chamber. You said apical septum, apical lateral, right?
Yes, sir. Yes.
Anything else in four chamber?
So basal anterolateral and basal introseptal.
We don't have a basal anterolateral in four chamber. I am asking you apical four chamber view. Which are the segments supplied by apical four chamber view by LAD?
Basal mid anteroseptum, sir. Mid inferolateral, basal inferolateral, and basal anteroseptum, sir.
I'm asking you again. My question is very simple. In apical four chamber view, which are the segments supplied by LAD?
So that's what apical. So LV, like interventricular septum.
What part of the interventricular septum? Vibhusha, this is very simple way. I'm asking you in four chamber view, what are the segments supplied by LED? Very simple. Apical septum,
Yes, sir.
apical lateral wall.
Yes, sir.
Then in two chamber view?
So in two chamber view, apical inferior,
And?
apical anterior,
And
mid inferior, mid
Mid-
anterior,
hmm.
and basal inferior and basal anterior. Sir.
So what is left in two chamber view?
So apical cap.
You said in apical two chamber view, all three segments of inferior wall, all three segments of anterior wall.
Yes, sir.
That's wrong.
Sir, can I give a try?
Yeah, go ahead.
Sir, in apical four chamber view, apex and apical septum is supplied by LED, and sir, apical lateral, mid anterolateral and basal anterolateral LED or LCX. And sir, in two chamber view, apex, apical inferior, and sir, the apical anterior, mid anterior and basal anterior is supplied by LED. In long axis
chamber view, yeah, long axis view.
Sir, in long axis view, sir, it is the apical segment, apical septum, mid anteroseptum, basal anteroseptum, and sir, one more is sir just in the below the apex, that is apical septum, I think, apical lateral or apical septum, one more part.
So how many segments are supplied by LED?
Sir, 1, 2, 3, 4, 5, 6. Sir, including apex, it is sir 11.
Including apex is 11. Okay, that's fine. Total 10 segments plus one apex is supplied by LED. Right? No.
Yes.
If you're counting on 17 segment model, 9 segments are supplied by LED. If you're counting on 16 segment model, 8 segments are supplied by LED. Listen now, very carefully. Wait a minute. Listen now carefully. Let's go to four chamber view. Apical septum, apical lateral wall, LED. Two chamber view, apical inferior and whole of the anterior wall supplied by LED. So 2 plus 4, 6. Then in three chamber view or long axis view, mid anterior septum, basal anterior septum are supplied by LED. So 6 plus 2, 8 segments are supplied by LED.
And sir, the crossover of either LED or LCX.
We are not talking of a crossover. We are talking of a conventional supply. Right?
Okay.
Let's remember a simple thing first, then we'll talk of a crossovers. Vibhusha, you have to spend some more time in understanding yourself.
Yes, sir.
You are too much confused with every segment. Either you are listening to 17 segment model or you listen to 16 segment models. My humble suggestion to all of you is listen to 16 segment model, because once you will go back to your machine to talk about these segments, machine will talk about 16 segment model, not 17 segment model.
So I will just study
Dr.
more.
Sanjeev Mathur, next question is for you. Sanjeev, are you there?
Yes, sir.
Why basal anterior septum contraction is important in acute anterior wall MI? Tomorrow you're going to be an echocardiologist back in US and you get an anterior wall MI and your consultant asks you, have you seen your basal anterior septum? Is it contracting or not contracting? What does it mean
So,
by?
sir, if there is a blockade in the LED, there shouldn't be good contraction on the anterior.
No, that's not the answer. Very specific answer for this.
So can you repeat the question one more time, please?
My question is, you're a cardiologist working in the hospital. You are doing an echocardiography of anterior wall MI who has just walked in the hospital at 12 o'clock in the midnight. You did an echo. Your consultant asked you, how is the basal anterior septum? Is it contracting or not contracting? Why your consultant is asking this and why you will say that whether it's contracting or not contracting?
So if he has an MI, an LED MI or a blockade in LED, there wouldn't be any contraction visible on the anterior.
No. Anybody else would like to take? Dr. Niranjan Agarwal from Bhilai.
This segment is supplied by diagonal vein, so it means the proximal LED.
Yes. Who's this person?
Sir, it means the left main is blocked.
Answer is very true. Somebody said this answer is, if its basal anterior septum is involved, it means the D1 branch of LED is involved. And D1 branch of LED is involved means the lesion is proximal to D1, if means left left LED which is proximally involved. And these people, they have a very poor prognosis unless until we intervene very fast. If D1 branch or basal anterior septum is spared, the lesion is after D1 branch, which is known as mid-LED lesions. So it's not a proximal LED lesion, it's a mid-LED lesion. So some supply is still preserved by LED. And LED is an artery which supplies to almost 50% of the myocardium. And that's why it's important. Many of time our previous students have done this. We told them this question. They were working in peripheries. They saw anterior wall MI. They looked at an echo. Basal anterior septum was not contracting. They did not try anything. They gave them heparin and they shifted the patient immediately to a nearby intervention center. You can do thrombolysis. I'm not saying that. You should not do it. But because this is a proximal LED lesion, the chances of thrombolysis are very poor because whole of the LED is filled up with either thrombus or some lesion. So that's the answer we should remember when we are doing an echocardiography for anterior wall MI and we look for basal anterior septum, right? I'll close down, Sanjeev, with one more question from you. In which view you will see basal anterior septum?
So the 4-chamber view?
I'll give you one more chance. Where do you see anterior septum?
The plaques view?
Plaques view and one more
And
view.
the 2-chamber view.
3-chamber view.
Oh, sorry, 3-chamber views. Yes, sir.
So if you happen to see in plaques window, you should go and confirm in 3-chamber view whether I'm seeing the plaques view correctly or basal anterior septum correctly or not correctly. Is that right? So you have to read a little bit more.
Sure, sir.
All right, let's move on to next. Rahul. Rahul, are you there? He's not there.
Yes, sir.
So Rahul, get ready for the next question. Left circumflex artery territory, Rahul. Quick,
Sir,
in
left,
2 minutes time, 1 minute time.
Sir, left circumflex artery in 4-chamber view supplies apical lateral, mid anterolateral, and basal anterolateral.
Okay.
And sir, 2-chamber it is LED LC. Yes, sir. In apical 4, these are the segments, sir.
Okay.
Apical lateral, mid anterolateral, and basal anterolateral.
Dr. Karthikeyan. Dr. Karthikeyan, will you like to try this question? He's not there. Dr. Karthikeyan is not there. Dr.
So may I try this? May I try this?
No, wait a minute. Dr. Ravikant. Dr. Subhash Chandra from Mohali.
Yes, sir. It supplies mid and basal anterolateral segments.
Gentlemen, we just talked about mid and basal anterolateral. Anything else apart from this? Dr. Khushpreet Singh, Chandigarh, Mohali. Kush. Are you there, Dr. Khushpreet Singh? He's not going to make us happy, you know. Dr. Umesh Kumar Oja from Jharkhand. In last 5 lectures, we have talked about this thing multiple times, not one time, multiple times. Dr. Oja, are you there?
Yes, sir.
Tell me
this
that.
supplies the, yes, sir. Major and mid anterior septum.
Don't do injustice, man. Anterior septum is not supplied by. We
No, sorry,
just
sorry.
talked a few minutes
Anterior
back.
septum.
We talked about a few minutes back about anterior septum is supplied by LED. It not looks good, Oja. Last, Dr. Venkatesh, you want to try this question?
Sir, apical lateral, mid lateral, and basal laterals.
And Dr. Sangeeta Chaudhary?
Yes, sir. It supplies the mid and basal segments of the posterior wall. Either it supplies or actually supplies segments.
Okay. The rest of the people, please silent your mics. So the correct answer is in four chamber view, mid and basal lateral wall is supplied by circumflex. And in 3-chamber view, mid and basal posterior wall is supplied by circumflex. It's a very simple thing. Only 4 segments are there to supply by circumflex territory. And the circumflex territory supply is dependent on a dominant artery, whether it comes from RCA or circumflex PDAs. All right. We can silent your mic, Dr. Sangeeta. Are we clear now?
Once again, for left circumflex artery, in 3-chamber view, what are the segments?
Mid and basal posterior segments. Remember, now I'm going to talk to you about all these segments in one go. Let's go to 4-chamber view. 4-chamber view has got 6 segments, 3 of septum, 3 of lateral wall. Septum, apical lateral wall is supplied by LED. Apex is always supplied by LED. Then rest of the 4 segments are mid and basal lateral wall, mid and basal septum. Mid and basal lateral wall is supplied by circumflex. Mid and basal septum is supplied by RCA. Let's move to 2-chamber view. Mid and basal inferior wall supplied by RCA and rest all is supplied by LED. Let's move to 3-chamber view. Anterior septum is supplied by mid and basal anterior septum is supplied by LED. Mid and basal posterior wall is supplied by circumflex. So 50% of the heart is supplied by LED, 25% is supplied by circumflex, 25% is supplied by RCA. And if you have a proximal RCA lesion before RV branch, then you have a RV hypokinetic. Majority of time RV branch is spared. And when RV branch is spared, you have hypokinesis of mid and basal septum and inferior wall, and RV appears to be contracting normally. That should be your answer whenever we are asking these questions again and again. And in echocardiography, this is bread and butter for everybody. Because what exactly the people are going to ask you, which coronary artery? I'm not going to talk to you why all these things happens, but at basal level, this is what we expect to understand. And this is a dictum. This is what we follow in basic teachings. Overlaps are many. Many of them are overlaps. If RCA is very dominant attached with PDA, it will go and supply the complete circumflex. So what will happen? Dominant RCA will involve mid and basal inferior wall, mid and basal septum, mid and basal posterior wall, maybe mid and basal lateral wall. If circumflex is dominant, it will go and affect the mid and basal inferior wall also. Dominant means a posterior descending artery which is attached to either circumflex or right coronary artery. In LED, the most important part is whenever you have an anterior wall MI, if you have a basal anterior septum which is not contracting, this means the lesion is proximal LED lesion. And if the basal anterior septum is contracting, then the lesion goes beyond D1 branch of LED and goes to mid segment. The prognosis of mid segment is better than a proximal segment LED lesion.
Sir, just one question here. Actually, the person who I answered had told that the diagonal is the one. The diagonal that I understand that it is proximal LED blockage, but isn't it the septal branches that will go towards the septum to perforate it, which also originate early, but diagonal goes more towards the lateral anterolateral surface?
Look, there are two kind of a nomenclature is there. One is says D1, D1, D2, D3. Okay. Some of them says as septal 1, 2, 3. On the other hand, obtuse marginal 1, 2, 3. Obtuse marginal, they arise from circumflex. Septal or diagonal, they arise from LED.
So, but anterior septum will be from the septal branches.
Septal
like
or
on the right side.
diagonal one, whatever it is.
Okay, D1 also.
D1
Okay.
also. Some people will say septal one as diagonal one.
Okay, okay.
Many variations are there. You know, like it's not that. Sometimes there's artery intermedius also. Like D1 is so big to begin with, like soon as LED arises, it gives rise to a large D1 branch, which is known as intermedius artery.
Intermediate.
Ramus intermedius. So large variations are there. I'm just talking of simple one diagnosis.
Okay,
sir.
Yes.
Sir, in the 17 model of the that is the segments, there is no posterior wall, sir, which you are actually referring. So, do you mean inferior wall as the posterior wall here, sir?
Wait a minute. Let me just show you that slide. You know, give me a second. I'll get back to the slide. Why I still say that we should adopt 16 segment model is because when we talk of all these things, in day-to-day practice, when we go to machine will give us 16 segment model even today also. And it become really confusing when we talk of other segments.
Inferior wall versus the posterior wall, sir.
Wait a minute, just give me a second. You know, like I'm coming down to that particular phenomena. It'll take me a time, minutes.
Yes, sir. Yes, sir. I will wait, sir. I will wait, sir.
Just give me a sec. Request, please silent your mic. You're creating a lot of noise in between. Okay, can you see this slide?
Yes,
Yes,
sir.
sir.
Yes, sir.
We look at these segments. These segments are 4 views, then another 6 window, 6 segments and 4 segments, right? If I go to 16 segment model versus 17 segment model, what the problem happens, we can change this nomenclature from the other one to this one, because this what we have learned over a period of time is basal, lateral, inferior, interventricular septum. Even this does not answer that correctly, because what we talk even today also, and I'll request everybody to remember this. This septum, we still talk of a septum because machine tells you this is basal septum, apical septum, mid septum, and basal septum. Apical lateral, mid lateral, and basal lateral. And this nomenclature has been changed by 17 segment model, just changing the nomenclature of these segments. This is complete anterior wall and this is complete inferior wall in 2 segments model. And same thing is when we go to long axis view, this is anterior septum and this is posterior wall. Once you talk of a 17 segment model, that segment model is derived based on MRIs. Many people, they're adopting that model, but the problem is when we talk of these models again and again, the only problem which we feel when we go to the labs is in echo machine, those models are, they're not adopted as such even today also. That they get adopted, it'll be great. Till that time, I'll still request again and again, please remember, rather than anterolateral, please simple remember the lateral borders. Otherwise, it'll become really confusing because some people says anterolateral, some people says lateral. And posterior segment is not there, that is known as infraposterior. And the basis comes like, look at this base over here. This is basal septums, this is septum, this is anterior wall, and this is what? This is anterior septum, this is septum, this is anterior wall. So what I always say is in front of anterior wall is always inferior wall. Anterior septum, opposite that anterior septum is always a posterior wall. Anterior wall is always inferior wall and septum is opposite is lateral wall. So I'll send that presentation again. Remember in that fashion, that becomes easy for teaching and for practical purposes. Tomorrow you'll go to the machine and listen. This will only talk of lateral and not talk of anterolaterals. Right?
Right, sir. Sir, in the book that you have sent, have you, sir, clearly mentioned all this for us?
Very clearly. I showed you this from a book only.
Oh, okay, sir. Thank you so much. Waiting
This
for
is
the
a
book.
presentation for the book only. The
Yes,
book
sir.
is already, in fact, we have sent you a soft copy of that book on your WhatsApp group also.
Okay, sir. But I haven't received, sir. I will check.
Yeah, please check it.
Thank you, sir. Thank you for your time.
Okay, like Dr. Umesh, you would like to take this question? Dr. Umesh, are you there?
Yes, sir. Okay.
2 important features for cardiac ultrasounds.
Two important features of cardiac ultrasounds. I could not get your.
What does cardiac ultrasound wave does in day-to-day practice?
The sounds are sent and they are received by the piezoelectric crystals.
So what do they do?
They analyze the
This is a very simple answer.
picture where
They do imaging, they give you a Doppler studies.
yes.
Very simple. 2 answers for this is they give imaging and a Doppler study. That's what the cardiac ultrasound waves are.
Yes.
Dr. Amit Vikram from Mungar. Amit, are you there? Somebody mic is still open. Dr. Rajshri Karat. Rajshri Karat, are you there?
Yes, sir. Yes, sir.
The question goes to you. The next question is for you. Difference between high and low frequency transducer. Your voice is not audible. No, it's not audible at all. The wavelength or the internet connection is not stable.
Sir?
Now I can hear you better.
Yes.
Rashri, you have to have some good internet connection. We are not able to hear you at all. Dr. Raj Rajendra Borkar.
Yes, sir. So with
Answer.
high frequency, there is better imaging resolution, whereas there is poor penetration with the depth. Whereas with the low frequency, we can have good depth penetration, but the image resolution will be poor.
So where do you use high frequency transducer? Where do you use low frequency transducer?
If the structures that are close to the surface of the body, like the anteriormost structures, then we use high frequency structures. In case of pediatric also, we can use it, sir.
Okay, fine. Good answer.
Thank you, sir.
Next question, Dr. Swapnil Datta, Chikli,
Yes, sir.
Maharashtra.
Yes, sir.
What are the basic imaging planes used for routine echocardiographic studies?
Sir, repeat the question, sir.
Basic imaging planes used in routine echocardiographic studies. Question is right in front of you, Dr. Swapnil.
Yes, sir, but I'm not getting.
What are the imaging planes we use while doing an echo study?
No, sir, no.
Okay. Dr. Parveen Kumar from Danapur. Parveen, are you there? Dr. Prashant Pandey from Varanasi.
Sir, there are three planes: long axis, short axis, and apical.
Four chamber planes.
Yeah, four chamber plane. Yes.
In apical axis, what are the planes which we see?
In the it's apical is a four chamber plane basically, and we can go for a 3 and 2 and 5 also.
What 5?
5 chamber view, 2 chamber view, 3 chamber view, 4
Correct.
chamber.
And long axis plane?
On the long axis plane, we can see 3 chamber.
In long axis plane, we see Plaque's window. In short axis view, we choose short axis views.
Short axis.
Okay, good. Dr. Ravi Kumar from Bihar. Ravi, are you there? Ankit Agarwal from Bareilly. Ravi Neelkant Patil. Sanika Sachin Kadam. Sanika, are you there?
Yes, sir. Yes, sir.
Ideal position of patient in apical and subcostal windows, views.
Straight position, sir, for the apical, the subcostal views.
In which
In
condition, in
apical,
which position the patient will lie in subcostal view?
costal view, so straight position with folded leg.
Correct. And in apical window?
Apical window turn to the left side. We check, go to the lateral side of the fourth intercostal.
All right. Thank you, Sanika. Anuj Kumar from Devgarh, Jharkhand.
Yes, sir. Yes, sir.
Direction of index marker in Plaque's view.
Sir, transducer is present third left parasternal, left third intercostal space with the index marker pointing towards 11 o'clock or towards the right shoulder.
What is the structure seen? No, it's done already. What is the normal dimensions of left atrium, left ventricle? What is the normal dimensions of left atrium and left ventricle?
So normal values.
Yeah, normal dimension values.
Sir, left ventricle, it should be less than 32 mm per meter square body surface area.
And left atrium?
Around
Doctor-
22.
Dr. Deepak Kumar from Ghaziabad. Left atrium dimensions, Dr. Deepak?
Left atrium is up to 40 millimeter.
No, we are not talking of absolute value. I'm asking indexed values.
I'm not remembering the index values.
Dr. Niharika, Chirola, Andhra Pradesh. Niharika, are you there? Dr. D. Niharika, Chirola, Andhra Pradesh. The left atrial dimensions is 22. Left ventricle is 32 millimeter per meter body surface area.
Sir, good evening, sir.
Are you there, Niharika?
Yes, sir.
Okay. So the next question for Niharika is normal left ventricle thickens or thins out in systole?
It thickens in systole, sir.
Okay. And what is difference between pressure and volume overload?
So pressure overload is pumping of left ventricle, pumping of the ventricles against increased pressure gradient, like example in case of aortic stenosis. Volume overload, where is the increased against increased volume, like conditions like ASD.
So the septum will behave how in pressure overload and volume overload?
Sir, in what septum, sir?
Yes.
In pressure overload, the right ventricular septum will be bulging towards the left ventricle, sir.
There's
In
nothing
pressure-
like right interventricular septum. Septum is interventricular septum will
is
bulge
bulging
towards left ventricle.
left ventricle.
When?
In pressure overload, sir.
In which part of a cycle of a cardiac cycle?
Systolic.
Systolic. And in volume overload?
Volume overload, it doesn't bulge. So
Good answer. When there is a D-shaped bulge during diastole and systole, this is pressure overload. When the D-shaped bulge is only during diastole, it is volume overload.
okay, sir.
You know a good subject. I'll go back to Dr. Deepak. Deepak, what constitute ECG systole and diastole? Deepak from Ghaziabad.
So ECG systole start from the start of QRS wave up to end of T wave. That is systole. And diastole is from end of T wave to start of QRS.
Okay, good. Next question goes to Vivek Dwivedi from Loni. Which cardiac cycle, in which part of the cardiac cycle, the aortic and mitral valve opens?
Sir, mitral valve opens in diastole and aortic valve open in systole.
If you relate to cardiac, like ECG?
Like aortic valves open during like P wave to QRS complex, and
P wave
mitral
or
valve.
beginning of QRS complex?
Oh, sorry, beginning of QRS complex. Sir.
To
T wave.
End of T wave. That is systole.
End of the T waves. Yes. Sir.
And aortic mitral valve?
From end of the T waves till like beginning of QRS complex.
What constitute P wave?
Ventricular repolarize.
P wave.
No, P waves, sir. P waves. There is a like and LA and RA, sir. Sorry, left atrium and right atrium.
So what does P wave represent in echocardiography?
P wave, sir. P.
Yes. It represents diastole. But
Yes, sir. Diastole.
so what does P wave represents? It
Systole.
represents atrial kick.
Yes, sir. Okay, sir.
All right. Reasonably a good answer. Dr. Narendra Sharma. Dr. Sharma, are you there? All right. What does Doppler record, Dr. Sharma?
Doppler, sir, records the velocity of the flow.
Alone velocity? Doppler records pulse wave, continuous wave.
Yes,
What does it record?
Records, sir, any turbulence of the blood flow across.
No, CFM shows color flow mapping shows turbulence. What does this Doppler? Okay, let's divide this Doppler into three parts. Color Doppler, pulse wave Doppler, continuous wave Doppler. What does pulse wave Doppler records?
Pulse wave Doppler records the low flow across the normal flow across the valve.
Well, whether it's pulse or continuous wave Doppler, all of them they record basically velocity and gradients and velocity time integrals. Right? I expected a good answer from you, man. Anyway, let's move to Dr. Devendra Pratap Yadav. Devendra, are you there?
Yes, sir.
What is positive Doppler shift? What is negative Doppler shift?
Sir, it's a velocity towards the transducer and against the transducer, sir.
Towards the transducer is it negative or positive?
Sir, if it is towards the transducer, it is positive, and away it is negative.
Example.
Sir.
Which velocity is towards the transducer, which is away from a transducer?
No, sir, I have no idea, sir.
Iqbal Mohammed. Positive
Yes, sir.
Doppler shift, Iqbal.
Yes, sir. Positive Doppler shift in case of aortic regurgitation, mitral stenosis, we see the positive Doppler shift. And in case of mitral regurgitation and aortic stenosis, we see the negative Doppler shift.
Very true. The flow when it's happening towards, in normal valves, mitral tricuspid flow will be positive Doppler shift. Aortic pulmonic will be negative Doppler shift. Mitral regurgitation, negative Doppler shift. Aortic regurgitation, positive Doppler shift. Pulmonic regurgitation, positive Doppler shift. One more, Mahmood. The pulmonary regurgitation will be seen during diastole or systole?
Pulmonary regurgitation, it's actually during diastole.
Why not systole?
Because in case of systole is RV eject the blood, so you cannot see the regurgitation.
Okay, good. Dr. Shahdab Raja.
Yes, sir. Yes, sir.
Three important Doppler modalities.
Sir, this M mode, sir. M mode Doppler.
Doppler, M mode Doppler.
No, sir. Sir, yes, C wave, sir. C wave Doppler, pulse wave Doppler, continuous wave Doppler, pulse wave Doppler, sir.
What is the third one?
The tissue Doppler, sir.
Okay, God. You are smarter, man. The color flow mapping Doppler, pulse wave Doppler, continuous wave Doppler, then the fourth one is the tissue Doppler. Right, okay. Yes. You should have said color flow mapping Doppler. Color flow mapping. Anyway, answer is reasonably taken. Dr. Anuj Jain from Khargaon. Anuj?
Yes, sir.
Doppler study, one should be parallel or perpendicular?
It should be as parallel to the blood flow as possible.
Why? Why can't be perpendicular?
Sir, because sir, it should make an angle with the blood flow, the obtuse as possible or as acute as possible.
No, I'm
With
asking
the
a
blood flow.
very simple question is, if I'm parallel to the blood flow, why I cannot be perpendicular to blood flow?
Sir, because in perpendicular blood flow, we will not see anything in perpendicular Doppler.
We'll underestimate the blood flow if we are perpendicular.
Yes.
If you are parallel, we'll truly estimate the blood flow. Okay. While imaging, you should be perpendicular or parallel.
While Doppler 2D
imaging, 2D imaging.
2D perpendicular.
Perpendicular. Good. Great job done. Aarti Jadhav. Aarti?
Yes, sir.
Recording valvular velocity where the sample volume is placed. Where do you keep your sample volume while recording the velocity?
Yes, sir.
Where do you keep the sample volume?
At the valve, sir.
Into the valve, away from the valve, tip of the valve, below the valve, where?
The below the valve.
You can revise your question, answer now. If you keep it below the valve, what will happen?
Sir, when we measure the velocities of aortic valve, we keep the below the valve, we get the proper velocity, sir.
In mitral valve?
Mitral valve, at the tip of the valve, we keep the.
We just keep distal to the tip of the valves.
Yes. Yes,
Not
sir.
below. If we keep below the valves, then we
No, in mitral valve, of course, we put at the tip of the valve.
all velocities are reported as a distal to the tip of the valves. In aortic is not below, is distal to the tip of the valves.
Okay, sir.
If it's my aortic valve, even then also it is distal to the aortic valve leaflet. If you keep below the aortic valve leaflets, it will be a LVOT, not the aortic valve.
Okay, sir. Yeah.
Right? So
Yeah.
remember this. Dr. Santosh Kumar from Bardhaman, West Bengal. Santosh, are you there? Santosh has become gone for Santosha. Dr. Sunita call. Dr. Sunita call. All right, absent. Dr. Paresh P. Alwani, Nasik. Prasanjit Panda. Prasanjit, are you there?
Yes, sir, I am there, sir.
Prasanjit, how are mean gradient and velocity time integral obtained from a Doppler tracing?
Sir, gradient means difference in pressure between two chambers.
I gave you a Doppler tracing. How will you get mean gradient? How will you get VTI? Suppose I kept a sample volume at mitral wall. When I kept a sample volume at mitral wall, I got a tracing of mitral valve Doppler flow. How do you get a mean gradient? How do you get a velocity time integral?
Hello. Sir, it comes automatically, sir, in the volume.
No,
In the
automatically
machine.
you will get it, but how you will get automatically?
Hello, sir.
No, sir, I can't take it.
Okay. Dr. Sheetal.
Hello, sir.
Yes, sir.
How do you get
Sir,
mean gradients and velocity time integrals?
With the help of the Doppler envelope, sir, if we keep
Hello,
at the
sir.
distal most point, we'll get peak velocity. And if we trace the Doppler envelope, we will get the mean gradient and the machine will
Perfect.
give the VTI.
Prasanjit, are you clear now?
Yes, sir, got it, sir.
So you trace the envelope. Once you trace the envelope, you get peak velocity, peak gradient, mean velocity, mean gradient, velocity time integral also by tracing the envelope. If you keep just at the tip of the leaflet, you are only going to get a peak velocity and peak gradients.
Right, right.
So always remember, we just trace them up rather than just keeping at the tip of the leaflets. So, as next question to you, Pasanjit, is when do you trace the envelope? In normal subject or in abnormal subject? Like you want to trace the envelope in every subject or in some special situations?
Sir, in cases of like tachycardia, hyperdynamic states, I
No,
like to
no.
increase the peak gradient increases.
No. Dr. Raghavendra, you want to take this question? Raghavendra. Dr. Prakash from Raichur.
Yes, sir.
Question, like to take, when do you trace the gradients? When do you trace the Doppler envelope? When do you just take a peak velocity and the gradients? In normal situation, what you'll do? In abnormal situation, what you'll do?
So may I answer this?
Dr. Niharika Terhan. Dr. Niharika Terhan, are you there? Amit Kumar Singh. Dr. Amit Kumar Singh. It's a very simple answer. No, I don't know why we are having so much of a problems. If you have a stenotic lesion where the gradients are very high, you want to really know what is the mean gradient like MS, AS, TS, then you have to trace the Doppler envelope. In normal subject, when the velocity is normal, why do you want to trace the envelopes?
Yes,
the question is, we'll only trace the Doppler envelope when we see that velocities are on a higher side or increased. In every case, you cannot trace the Doppler envelopes. Suppose, what is the normal velocity, Dr. Pasanjit, of aortic valve?
Aortic valve, sir, it will be 1 to 1.7, sir.
It is
Meter per
maximum is
second.
1.7.
Sir,
If the
average
velocity
will
is
be-
up to, no, not
sir.
average, up to
Sir, sir.
1.7.
Sir,
So if the velocity is up to 1.7 meters per second, why I'll trace the Doppler envelope?
correct.
Right? If the velocity is 2.5, then I'll try to trace the Doppler envelopes.
Sir.
Are we clear about this particular phenomenon?
Got it.
Okay. Dr. Sunita Kaul, tell me what are the two important advantages of color flow mapping? Dr. Sunita Kaul, are you there again now?
Yes, sir. So if the lesions are regurgitant, we can at least look the gradients.
Lesions are regurgitant, we can look the gradients. No. How can you look at the gradients by color flow mapping? The gradients are looked by Doppler flow pattern, and by doing a continuous wave Doppler, then tracing it, then we'll get a peak and mean gradients. What is the two important advantages of color flow mapping? No idea? Dr. Sunita, any idea about this? All right. The two important advantages for color flow
So
mapping
basically,
is
it's flow into the great vessels. We can just see the volumes.
no, we cannot see the volumes.
Which
The very
shows the
simple
velocity or any turbulence.
No, it will tell you about the direction of blood flow. and whether the flow is laminar or turbulent. That's one advantage. Second advantage is we look at the regurgitations, where the regurgitation jet is going behind the leaflets, whether it's central, medial, or lateral. Before color flow mapping was available, we used to keep our sample volume behind the leaflet and move it around medially, laterally, and centrally, so as to get the answer where the regurgitation jet is. Similarly, in mitral stenosis, you remember the jet could be in any direction. If not in mitral stenosis, in prosthetic valves. So we have to keep our sample volume in the line of a blood flow, parallel to the blood flow. And that is the two color flow mapping advantages we have got. By looking at a color flow itself, you can tell whether this flow is laminar or turbulent. I have told you this question when I was talking about color flow mappings. I'm sorry, you had no idea about this. So we are almost closer to our session for today. And as per universal convention, what determines the blood flow of color on a color flow mapping? Anybody would like to take this question can raise their hands. 3 participants. Dr. Veerwar, you did not take up this question. As per universal convention, what determines the blood flow color on a color flow mapping?
Sir, a flow towards the transducer is imaged as red, and a flow away from the transducer is signaled as blue.
When turbulence happens, what happens with the turbulence?
Sir, orange color.
I say during turbulence, it becomes blue in color. Will you accept that?
No, sir.
It can. Why not? When the Nyquist limit is 60 centimeters, if the blood flow velocity is about 1.2 meters per second, the flow would be labeled as red or blue in color over there. As per universal convention, what you said is right. But when turbulence happens, you can see a mosaic color of color pattern.
Mosaic colors.
So mosaic is what? The mixture of all colors. Okay, good answer, Virwar. Did a good job. Next question goes to, are the jets of mitral pulmonary regurgitation red or blue in color? Listen to this question very carefully. And anybody can just first cancel your hands and then raise your hands. So I'll give this question to Dr. Anuj. Anuj, are the jets of mitral and pulmonary regurgitations are red or blue? Let's take mitral first.
Mitral will be red color.
Anuj, your mic is not good. Can you speak slowly and clearly?
The jet of the mitral regurgitation will be red in color.
Oh.
Hello.
You did not pick up a correct answer. You know,
Oh,
Dr.
hello.
Dr. Pankaj.
Yes, sir.
Hello, myself.
Yes,
Anu,
sir.
sir.
Mitral regurgitation will be blue and pulmonary regurgitation, it will be red.
Dr. Pankaj, I asked this question very cleverly, you know, like,
sir,
is the mitral regurgitation jet, what is the mitral regurgitation jet velocity is?
So can't get the answer actually.
60 to 1.3 meter per second, sir.
The mitral regurgitation jet velocity is the difference between LV and LA. LV pressure is 120 millimeters of mercury and LA pressure is only 10.
Sir.
The velocity has to be more than 5 meters per second or 6 meters per second. Will the color wave only be blue? It will be a mosaic color of pattern. Go back and look at your mitral regurgitation jets. They are very high flow velocity jets.
Sir.
So they have not have a red or blue colors. They'll have all mosaic color of patterns. Whereas the regurgitation of pulmonic regurgitation would be red in color.
Red in color.
Because the pulmonic artery pressure is how much? 25. And RV pressures are only 10 millimeters of mercury. So difference is 15 millimeters of mercury. The question is very intelligently placed. Is that clear? Now go
Right, sir.
back tomorrow and see this question in your machines.
Right, sir.
So what is Bernoulli's equation, Dr. Narendra Kumar?
Bernoulli, Bernoulli principle said that the increase in the speed of the fluid occurs simultaneously with a decrease in the steady.
No, I'm asking a very simple question. Somebody is talking on a phone. Please silence your mics.
Sir, it's 4 into velocity square.
4 into velocity square is Bernoulli's equation. That is modified Bernoulli's equation. So if you have got a gradients of 4 meters per second, if you have a velocity of 4 meters per second, you change it to gradient, that'll become a Bernoulli's equation. Is that clear? From which structure RA pressures are derived? Anybody would like to take this question? Can open our mic and say swiftly.
Yes, sir.
IVC, sir.
Go ahead.
IVC. IVC.
IVC. Very simple.
Right, sir.
IVC. What is collapsibility index of RA pressures?
Sir, may I?
Go ahead.
Less than half, sir.
Sir, in hypervolume it is 21, in hypervolume it is 12.
That is a diameter, you know. Collapsibility index of
less than
RA
half,
pressure.
sir. Less than half, sir.
More than 50%.
More than
It is more
50%.
than or less than 50%.
Collapsibility of IVC will determine the pressure in the
Correct,
right
correct.
volume.
So maximum minus minimum divided by maximum, that will be a collapsibility index. In normal subject, what is the collapsibility index?
50%, sir.
More than
50%.
More than
50%. Name the echo windows for interrogation of tricuspid regurgitation.
Sir, may I?
Go ahead.
That in
Sir, four
subcostal view, we can
Wait a minute. He's telling you the answer. Go ahead.
Sir, four chamber apical view.
Okay.
RA, RV inferior view.
Inflow view. 2.
Subcostal view.
3.
नहीं और एक नहीं पता सर.
It is like you go to Plaque's window. We do not see an IV tricuspid regurgitation. From Plaque's view, you drive RV inflow view.
Okay, sir.
Then you go to short axis view at aorta. You get tricuspid regurgitation. Short axis view at aorta. Then you go to apical 4-chamber view. Then modified apical 4-chamber view or focused RV inflow view.
Okay.
And 5th is subcostal window. And you have to take the peak of these, not the average of these. Wherever we get the maximum, we have to utilize the maximum velocity gradients.
Okay,
Right?
sir.
Okay.
Okay, sir.
Next question is, based on Doppler, what is the main criteria for increased pulmonic artery pressure? Anybody? Go ahead.
jet velocity more than 3.4.
PR jet velocity more than 2.8 meters per second. 2.9 is a cutoff. And very simple way of remembering it, remember 3 meters per second. If somebody has got a velocity of 3 meters per second, possibly he has got an increased pulmonary artery pressure. 3 transform into what? 3 into 3 into 4, 36 millimeters of mercury. 36 plus RA pressure, 5, 40.
Plus
40
2.1.
Plus 40 divided by 0.6, 24. Add 2.1 is 26.1. Anything more than 25 millimeters of mean pressure is considered as elevated pulmonary artery pressures. Clear? If the velocity of tear jet is 5 meters per second, RM pressure is 10. What is the peak pulmonary artery pressure?
110.
110. 5 into 5 into 4. 110. Great. And what would be the mean? (66) plus 2.1 is 68. 110 multiplied by 0.6. There'll be 66.
68.1.
68.1. Is it normal or elevated?
Elevated. Sir.
Elevated. Anything more than 25 is elevated. What is the 2D feature of pulmonary artery hypertension?
Dilatation of the pulmonary artery.
Okay, fine.
RV dilatation.
RV dilatation.
RV dilatation.
D-shaped IVS.
D-shaped septum in short.
D-shaped septum when?
In both phase, systole and
Diastole and systole.
both phase, sir.
Yeah, both phases. If there's a D-shaped septum during systole, what does this mean by?
McConnell sign.
McConnell sign is not D-shaped septum. I'm sorry.
It's only volume overload, maybe.
No, D-shaped septum during systole means the RV pressure is more than LV pressures. So if you take your blood pressure, if it's 100 millimeters of mercury, if the septum becomes D-shaped during systole in LV side, it means the RV systolic pressure is more than 100 millimeters of mercury. Correct?
Yes, sir.
This is a little difficult. I'm not going to touch this question. What are the ideal scan plane for study Doppler mitral valve?
4-chamber.
Apical 4-chamber view.
That's all?
2-chamber view. 2-chamber view.
4-chamber, 2-chamber, 3-chamber, 5-chamber, and
short axis.
short axis, very short axis mitral valve, man.
The planimetry we do in the short axis to look for the size, no? In parasternal short axis view.
Parachute short axis view at mitral valve. I'm asking Doppler. I'm asking Doppler.
Sorry.
Sometimes plaques view in COPD patients. The window becomes such, it looks like 3-chamber view. Where do we measure aortic flow velocities? In which all views? Mahesh, go ahead.
Sir, we can check in 5-chamber view, then 3-chamber view also. Aortic, then yes, these are the two view, 4-chamber and 5-chamber and 3-chamber view will be the better.
Total 6 windows are utilized for assessing aortic flow velocities. 5 and 3.
Subcostal.
Subcostal 3.
Subcostal, yeah.
Suprasternal.
Suprasternal 4. Right parasternal 5.
Right parasternal.
Right.
Parasternal short axis view available out.
सारी रात रामायण पढ़ी सवेरे
it will
सीता किसका बाप था?
perpendicular. Sorry, sir. It will be perpendicular.
We have showed you one view, which we say right anterior oblique view, which is a combination of right parasternal as well as suprasternal window. So total we utilize 6 windows when we are doing aortic flow velocities. And wherever the maximum is, we utilize that velocity pattern for a maximum flow. And in our experience, right parasternal window has maximum time gives you a highest possible velocities. So never forget about right parasternal window. Okay. Where do we measure pulmonic flow velocities?
For external short.
Short
RARV.
Short axis, sir.
Parasternal short axis view at aorta. One.
At iota.
Where else?
Sir, plaques view tilt to the probe to the upwards.
Plaques
RARV.
RV are in
Suprasternal not
no. We do not see in RV are in flow view. We do not see in suprasternal notch.
RV outflow view.
RV outflow view, correct. 2. Where else?
Pulmonary
Short
artery
chamber view.
outflow view.
Short axis and aortic.
Subcostal window.
Subcostal view.
3 places. All right, I think we are all tired, including me and yourself. So let's put a stop over here. But I'm really sorry. Many of you are not really good when we are asking these questions. And many of you have disappeared already. Out of 73, only 53 are present, including me. So please read, it all depends on you. And it is going to benefit you, not me alone. So next time onwards, we'll be starting our valvular lesions. So please listen to those lesions again and again. Meanwhile, whatever you have seen or learned previously, please go through them again and again. And that's how we can say that we can do some good job when we're doing echocardiogram. With these few words, let me say goodbye, Shabba Khair. Stay safe, and we'll meet next week. And maybe next week we'll let you know we are changing some time based on your availability. We'll push on our WhatsApp. Either we'll keep an early morning or maybe a little later. It all depends because I'll be sending that on a WhatsApp meeting. Maybe we'll keep it at 8 o'clock in the morning, early morning, or 7:30 in the morning. So with this, goodbye, stay safe and enjoy your dinner. Bye-bye.
Sir, will there be any question or exam session again, sir, next week? Because
There's there's no question session again next week.
Okay, sir. It will be only the subject, sir.
Subject only, directly now.
Stenotic lesions?
Mostly stenotic lesions.
Thank you, sir.
Kindly do not keep classes in the morning hours, sir. We have our duties in the morning. So it won't be able.
So we have to change a date because on Sunday, there's an important 3D echo session is coming up. Two international
Any day we
faculty.
can attend, sir, but in the morning it won't be possible.
Better to change the date. Morning is a
Keep on Sunday only, sir. Keep on Sunday.
So we'll keep on
Sunday only.
We'll
Sir,
send on a
you
WhatsApp.
can actually combine 2 classes, sir. So you can make actually 2 classes combined. You can start an hour early and try to make 2 classes in one.
We'll see that. I'll send on a WhatsApp. You can send me according to your replies. Okay.